Hi, everyone. Welcome and welcome back, Kelly. We've missed you. We're so happy to have you back. And thank you, Dr. Kunz, for being here. Dr. Kunz is our addiction medicine specialist from Hawaii Island Fentanyl Task Force, who we just found out is newly retired. So congratulations, but we still will be bugging you to come visit us here on Echo. Just a couple announcements. If you are new to Echo, if you could please put your username as something identifiable for registration purposes, first and last name. Also, if you are signing in from a cell phone, if you could just chat me or direct message me with your name so I can get your CE credits issued to the right person. Other than that, without further ado, I will stop sharing my title screen and hand it over to Dr. Kunz.
Thank you, Summer, and thank you, Kelly. Let me get the slide up here. Slideshow. Great. And hi, everybody. Good morning. I'm glad most of you had your coffee and tea. And, you know, one of my favorite sayings is we all live, one of the places we live is in the United States of drugs. And so a good proportion of you had drugs this morning before you were up and about. And you don't think of that as a serious drug, and it probably isn't. In fact, as some of you read in local news, a cup of coffee a day will increase your footsteps by 1,000 and decrease your sleep by 36 minutes. So coffee is a drug, it works on the brain, and I wouldn't be talking to you today without it. Okay, so I think if you put on some of the slides have some detailed information. So if you can minimize the gallery, you'll probably see more. And then I'll ask for Summer's help on maybe one or two slides. So I'm very happy to be talking to all of you and the work you do. I know it's a very mixed group. And one of my life problems is I don't like doing the same thing twice. So I keep changing up slide decks. So this is a little different if you've seen me talk before, or if you know anything about buprenorphine, which I'll call Bupe here, it's just another angle of looking at it. Oh, and then I can do the slides this time. I'm coming right along. Okay, so let me block out this up here. So today we're talking about a molecule, also a medication known as buprenorphine. That's a picture of it. I put the picture there because I'm going to be showing you some molecular pictures again today. And I want you to think of the human brain and in fact the human body as a big erector set. It's all these pieces that fit tightly together. And like a watch with a million different gears, or more like a billion, and the shape of those is important. So Bupe or buprenorphine, and we call it Bupe because if you talk a lot, we don't want to use that long word, so we call it Bupe. It comes in two forms. It comes in a form that is mixed with naloxone, which you know as Narcan as well, and that was a myth and a misunderstanding, and was thought to be diversionary, that people would not inject it because they'd go in withdrawal. I don't know if there's a single case report on such an incident, but it was meant to make it less desirable to inject. It comes in a pill and a film form, and the film form comes both with and without naloxone, as does the pill. The importance of the film form is, like all pharmaceutical companies, they have set doses they want to sell. And so when you're taking someone off a medication, whether it's a blood pressure medication or one of the questionable psychiatric SSRIs that are used today, titrating down is very difficult. But the film, when you're titrating someone off of Suboxone or buprenorphine when they want to get off, you can cut the film in smaller pieces. So it comes in 8 and 2 milligram sizes. So we're just talking about Bupe today. I'm not going to go into naloxone and all of that. And so Bupe is the topic today. Oh, hold on. This is an outline of, sorry, still getting there. An outline of the talk today. Death is a crude measure of health. There still exists substantial systemic discrimination against all persons with substance use disorders. We're going to talk about the science of opioid addiction and Bupe, how to start patients on Bupe, general guidance, then something about pain very briefly, and questions. This is, I'm going to turn this back to this slide so Summer can put it up. Slide 4, Summer. Thank you very much. First time I did a slide like this was probably 20 years ago. Drug overdose was not even on the chart. You can figure this out as well as I. There's about 3.5 million annual deaths in the US each year. And then you can get this data directly from the CDC or other sources. And I don't have to tell most of you because it's in the general public news that in 2021, there were over 107,000 drug overdose deaths, most of which were opioids, and most of the opioids involve fentanyl. So if you're in healthcare and you don't know about addiction and drug use, you're out to lunch. And so the American healthcare system really has been out to lunch for a long time. We've learned to be experts at taking care of lung cancer, at trauma, at liver disease and transplants, et cetera, but we have missed the underlying cause for most of these. Okay, now I'll take control again, if I may, Summer. After my snarky comments here, let's see, how do I do that? Share screen, okay. Back we go. Okay. All right. This is from Nature about 2 years ago, Nature the journal, and slides on the right, picture on the right, we think we've seen plenty of times with lots of different drugs, most recently fentanyl, but on the right is not fentanyl. On the left is the various drugs over the last 30 and 40 years, going back 20 years on the left and 40 years on the right. And you can see that there's a variety of different drugs, different ways they've been used, different variations of them. But if you look at overdose deaths overall in the United States of America, what you see on the right is the exponential curve. So we have never touched, we have never slowed down overdose death rates in America from drugs. So, and that's not going to change, and all the Narcan in the world won't change this. So we've got to go upstream at some point. I'm not talking about that today, but we cannot win this war. This is as silly trying to win the war of stopping overdoses as it is to have a war on drugs, which now even the DEA admits it was a failure. Okay, the local situation is grim. I had the distinct, horrible feeling a couple of weeks ago on a call with a federal person who said, oh, actually, you guys in Hawaii are doing pretty good with your overdose deaths. Hey, man, you got nothing to worry about over there. Gosh, that's really great. Because it's easy to compare with other places. But here in Hawaii, we have one overdose death, one drug overdose death every 36 hours. You can look at this yourself on this slide, and the slide set I'm sure Summer can make available for those that want it, is the link to get to this site. You can plug in Hawaii state and then each county. And if you add them all up, it's about a death every 36 hours. On my island, we have a death about every 11 days. And alarmingly now, as the trend is across the country, many of those are young people. The other issue with this notification of death, certainly if there was a serial killer in the state of Hawaii and somebody was killed every 36 hours, everybody would be up in arms. We'd be doing a lot about it. But we don't do much about opioid overdose deaths or overdose deaths in general. And quite frankly, in terms of healthcare, the industry has been lax in addressing this illness. A big problem here, and you can see this there, that these are provisional drug overdose deaths by county. And the latest, this was last night, I looked it up again, was June of 22. We are now basically 8 or 9 months later, and we don't know what's happened recently. So it's not a very dynamic, up-to-date. So once in a while we'll hear, oh yes, there were 2 overdose deaths in Hilo 2 months ago. Everybody heard about that because 2 on the same day. And one of them was 14 years old, the other was 18. So everybody heard about it. But other than that, you don't hear about it for 10 months, if at all. Additionally, we have no demographics from the federal or state government on this. So those are real losses. So let me just tell you from the street, and I'm really a street doctor, it's bad. And it's not getting better, and it's going to be worse this year than last year. And everyone involved from the DEA down agrees with that. Also, Summer asked about questions. You can ask a question anytime on chat, and then Summer can interrupt me and I'll try to answer it. We have a long history of systemic discrimination for persons with substance use disorders. The availability and access to services, if you have the disease of addiction, is extraordinarily limited, and that's systemic in its basis. These people should do better. Why don't they get it together? That's been long-standing. So compared to any other fatal disease, we give less attention to this. There's less availability and access to services. The insurance and pharmacy policies are terrible. I don't have to tell you that if you work in the field. Getting prior authorizations to send a 16-year-old that's pregnant to treatment, you have a little bit of luck, but after that, it's harder and harder. So it's hard to get help when people want help. The policies are not driven by expert opinion. They're driven by bean counters or people who don't understand addiction. There's limits on the type of treatment and the length of treatment. Until a year ago, and one insurance company, I believe, is still limiting the length of time you can be on a buprenorphine. There's excessive monitoring requirements for people on medications that have opiate use disorder. The worst example is methadone clinics, where you have to basically live part-time in the methadone clinic. You got to be there every day. And on this island, for instance, that's a 2.5-hour drive one way every day when you start, 5 hours a day on the road. How can you work? How can you take care of a family, et cetera, et cetera? So those are archaic. There's also the crime versus disease mode. I don't get too political very often, but blame versus care. But you know, the red states are more into it's a crime and the blue states are into it. It's probably a disease. They've got more services available. Massachusetts is a good example. California is another that has services readily available. So the blue states think the red states need treatment, and the red states think the blue states should be locked up. Anyway, that's America today, at least on that issue. I want to talk about language just a minute. We talk about that a lot in substance use disorder treatment, how language makes a difference. And some of the language around medication for opioid use disorder has been horrendous. Medication-assisted treatment. Well, isn't every medication a form of assisted treatment? Don't we want the patient to do something for themselves for everything? So we're calling out opioid use disorder and alcohol use disorder, for which we have very effective medications, separately than other diseases. That's part of the systemic, long-term, ingrained discrimination against this disease and people that have it. Medication for opioid use disorder is kind of a little better. I mean, it's really trying to let people know, oh yes, there is a medication for opioid use disorder. Well, methadone's been around over 50 years and buprenorphine's been around now over 20. So people aren't getting it. But when we make it something special, are we not making it something that people might look twice at, whether they're prescribing it or taking it? And one that's really bothersome is that in buprenorphine, it's talked about inducing the patient or induction of buprenorphine. Well, I can tell you, it's easy to start it. It's just starting another medication. And any provider that's ever started anybody on insulin will know that insulin's a lot harder than buprenorphine, but everybody can do that. And if it's a hypertensive medication, it needs adjustment, et cetera, et cetera. So there is this ongoing systemic discrimination for persons with a disease of addiction and their care. And hopefully that will gradually change as more and more people become interested in this topic. Unfortunately, the interest is being driven by the high death rate, high incarceration rates, high unemployment rates, broken families, et cetera, et cetera. Okay, just a quick note on Bupe and methadone. On January 12th of this year, all the restrictive Bupe laws and governmental policies were rescinded. It is now just another medication. It is a controlled medication, so a provider needs their DEA registration, but there's no other restrictions on it. That's huge. It's been 22 years that it's been restricted and made special. And obviously the powers that be got this changed because our children are dying. Now, recently, there's a movement to have methadone removed from these same restrictive, archaic, and discriminatory Drug Enforcement Agency rules. And this has been led by the chief of the National Institute of Drug Addiction, Dr. Nora Volkow. Just another medication that can actually save lives. So there's a great resistance to this. The resistance is coming from the organization of methadone treatment providers. And although in Hawaii, the methadone treatment providers are in nonprofit settings, that's not the case across the country. And so everyone wants to hold on to this punitive, lucrative financially model. So methadone is a safe and effective medication when used properly. Buprenorphine, for all who know the treatment of opiate addiction, know that it's a far superior medication, not just social-wise and policy-wise, but its effectiveness. So today, I'm going to talk about addiction, the brain disease, and opiate addiction in particular. I'm going to drill down. I'm not going to talk to vulnerabilities for addiction, such as the genetic, although I'll mention one genetic piece, and environmental, and I have to mention one environmental piece. No one will ever get addiction if they don't use drugs. Well, that sounds too hard because most of you are drinking coffee already, so one leads to the other, as you know. At any rate, the other environmental thing is if you can put off, if a person can put off using addictive drugs until the age of 25, it's unlikely they'll have the disease of addiction. I'm not going to talk about the sequelae of addiction. I can tell you that it is America's most expensive disease. If you add up all the cost and the way those are added up for other diseases, such as cancer or diabetes, we're more expensive than all of those put together. When you put treatment in there, incarceration, et cetera, et cetera. Okay, so we're going to talk about addiction as a brain disease only, and I'll try to limit any other comments. Okay, so understanding basic brain science makes using Bupe easy. So this is a great example of, if you know what you're doing, it's kind of easy. So this is the background. So I've heard some of you are from outer islands, so you live on outer islands, and I guess I live in Volcano, Hawaii. But the truth is that none of us live where we think we live. We live in our brain. That's where we feel, that's where we think, that's where we respond. So this wonderful computer of the brain with its billions of nerve cells is where I live. That's where my head is, literally. We know in the brain there's reward pathways that keep us doing some things that are good for us, like eating when we're hungry, sleeping when we're tired, et cetera, et cetera. So let's look at the brain a little bit, and I'm going to drill down to a level you may not have seen before. Before doing that, I'll mention again that if a person can put off using substances until they're 25, because about 25 years old, within a year or two, the brain has fully matured. It actually hasn't matured, it's actually pruned itself to its final state. But you can see the light green and yellow areas, that's the frontal lobes, the decision-making areas, judgment areas, and they're really not completely developed until a person is 25 years old, give or take a couple of years. And of course, this explains why teenagers are so unique. Okay, we go in the brain a little more, and the cells in the brain talk to each other, one to the other, multiple connections through synapses. The cells don't actually touch one another, but they're close, and they spit out a ligand or neurotransmitter. On the bottom right, you can see that, and the other cell has a receptacle for it, and we call those receptors. So one cell spits out a neurotransmitter, and the other cell catches it perfectly in a receptor. I'm going to show this slide 3 times. For this part, I only want to show you the upper left. If you could attend to the upper left hand picture, that's the bilipid layer membrane of a nerve cell with a receptor embedded into it, that green globular 7 subunit piece. On the slide immediate to the right of that, when the ligand or the neurotransmitter lands where the arrow is on the side, it opens the channel like a donut, chloride ion goes through, and the cell is turned on. So this is the action of a neurotransmitter. On the top slide on the right, when that neurotransmitter lands where the arrow is, and that's a model of the opioid receptor, when it lands there like a spaceship landing at the space station, that ring pops open, chloride ion goes through, and that's the switch that turns on. So getting down into the molecules and don't want to put you to sleep. So those of you, I think, don't eat your lunch too fast, you go to sleep on me here. So the opiate receptor is a very popular thing. And here's another rendition of it. The bilipid layer membrane, embedded within it is the opiate receptor. These opiate receptors, the conformation and the sequence have all been figured out by X-ray diffraction crystallography or new software. If you have the amino acid sequence, you can actually do this with a computer. It's so popular in our country these days that this is a wall poster put out by Fine Art America. I couldn't believe it. I felt like I should get one. But anyway, I'm sharing it with you, and I don't think I'll get one. So what happens at that receptor and when the ligand gets there? This is from about page 40 of Goodman and Gilman, the textbook that is still used for all biology and medical training in America, and it is not just pertaining to buprenorphine or opiates. So when a neurotransmitter goes to a receptor, there's a few things that can happen. The top line is a full agonist. It works really well. The blue line is a partial agonist. It works, but that's not as strong as the first one. The black line is something that's inactive. So coffee does not go, unfortunately, to your opiate receptors, or maybe fortunately. And the inverse agonist, when that goes to a receptor, then it will reverse what's going on. And the classic for us is naloxone. So this is across all neurobiology. The only thing that may be a little different is that the top green line, if it's an opiate, the body, the brain can continually tolerant to it. So that green line just keeps going up and up and up and up forever. So you see people taking inordinate amounts of opioids, especially at the end of life. So, okay. Well, here's a picture of that receptor again, 7 subunit, embedded in the bilipid layer. And on the top, on each side of the bilipid layer, there are some components of it. So there are 3 things the ligand can do on a receptor. 1, it can have an affinity for it. It wants to be there. 2 is its activity. And we've talked about activity, and I will again with this slide. And the other is dissociation. How long does it leave? So on the left side there, that's an opioid receptor, endorphin receptor with an endorphin in it. But heroin, the red, displaces the endorphin, takes its place. And you can put more in than your body would give you of endorphins. In the second picture, there's, let's call it heroin in place, but it could be any opiate. You put buprenorphine in, it has a higher affinity for it, so it pushes it out, and buprenorphine stays in there. But as you know, its activity does not make you high, generally. You accommodate it, you don't get high, and it also takes a while to dissociate. So unlike fentanyl or heroin, it sticks around for a while. And on the far right side is Narcan, which you're all familiar with. No matter if any illicit opiate, heroin, fentanyl, even buprenorphine will be displaced by Narcan. Okay, I think that's the my last neuro receptor slide, and this one's only in there, it's not a label, but this is a picture of fentanyl inside the opioid receptor. And that's our big deal today. So back to the opioid receptor, I'm going to look at the second bottom line now. On the bottom middle, you can see an enkephalon, a cousin to an endorphin, and you see on the left side an arrow pointing to a tyrosine moiety. So, and this is all conformational in our body, the big erector set. So that's our natural enkephalon. No one's ever synthesized our own endorphins or enkephalins, only we can do that. But if you look at the right, there's the morphine molecule. And you all know that heroin is just 2 morphine molecules tied together that as soon as they pass the blood-brain barrier, they separate. But there's the morphine molecule, whether you're shooting heroin, smoking heroin, or taking morphine from your doctor. You can see that works by the presentation where the arrow is of that same tyrosine entity, those 3 black carbon atoms. And so it's going to fit in the receptor just as well. And on the left side, you see buprenorphine, another cartoon of it. You can see that same tyrosine ring, the 6 white on the far left side. And so that's the magic here. That's why we get addicted to any drug, because drugs of addiction mimic or modify the brain's own neurotransmitters. And you could take any one of these bottom 3 drugs, they would land on that arrow on the upper right and trigger the receptor to open. The difference is, of course, is that morphine has full activity, buprenorphine has partial, and you can visualize that. These extra arms, buprenorphine actually starts off from thebaine, from the opium plant, and is semi-synthetically changed to put those big bulky arms on it. So it gets to that receptor site, but doesn't fit all the way in and sticks there. Thus, it's a partial agonist. Okay, last one on this. This is the amino acid sequence of the 7 subunits of the opioid receptor in mouse, in rats, and in humans. And they're remarkably similar. All 372 amino acids in the sequence are remarkably similar. So we can study rats and mice and do quite well understanding some of human behavior. We miss that, though, and we say, this person with addiction seems not to have any contact with anything except getting its next whatever. And its next whatever for the rat is the food, and the next whatever for a rat that's become addicted to opiates is more opiates. So that's the amino acid sequence through all species, pretty similar. And the remarkable thing here is that the bottom line, where I know you probably can't see this, but there's little X's under some of them. That's where we know there's a polymorphism. So a single nucleotide polymorphism means that the amino acid that's supposed to be there won't be there. Now that makes a difference in genetics. About 10 years ago, there was a study done of mothers and their babies. They monitored the mothers during the pregnancy. They were opiate dependent mothers. They were then put on buprenorphine or methadone. They did genetic studies on them. And when their babies were born, they studied the baby's withdrawal and their genetics. And what they found was that certain genetic changes made for the baby a much more difficult withdrawal, a neonatal withdrawal. So while we can, quote, blame, end quote, our adult patients for, you kept using because you just aren't going to meetings and not doing what we're telling you. You can't say that to a neonate that's just born. So this is the genetic basis for some people having propensity toward addiction because their withdrawal is different based on the fact that that neuroreceptor is a variant of normal. Okay, this is my last funny slide for those of you that don't like neuroscience. We also know that these receptors go up and down depending on what's happening. So downregulation refers to when a cell is continually stimulated with an agonist such as fentanyl or oxycodone or morphine, and it becomes desensitized. We often refer to such things as tolerance, but it's a little more detailed than that. So it decreases the receptor availability. It downregulates the number of active receptors. And so this is an adaptation. It's also referred to clinically as tachyphylaxis, when your body just gets used to it. And upregulation, you see clinically, refers to an increase in the number of receptors due to prolonged deprivation of receptors of interacting with their physiologic neurotransmitter. So both acute and protracted withdrawal have this. And, don't we all wish withdrawal was just 2 weeks? It's really up to 2 years as this upregulation continues to happen. Okay.
We have a couple questions.
Okay.
Is there a correlation between trauma and addiction?
Yeah, I wasn't going to talk about environment, but if you're in the field of addiction or counseling or medicine today, and you're not familiar with trauma-informed care, it's time to stop what you're doing, take a week off, and get on the internet. So I would assume that everyone here is familiar with adverse childhood experiences. And just like they predict addiction, just like they predict many other chronic diseases. So trauma is part of the vulnerability to addiction because it will give relief.
Between IQ and addiction?
Yes, the smarter you are, the less likely you are to take help. I would say that's true, that the person that thinks they can figure it out is in the most trouble. So technically, no, there's no difference in IQ. There's a difference in education, but I can tell you, we see plenty of educated people with addiction. They don't go down as fast. Does that answer the question?
Absolutely. There's another one, but I'm going to say later.
Okay, so so we're done with the brain science, I think. And really now, if you're going to use Bupe, the only thing you really have to understand is opiate withdrawal. And you don't have to understand that at that level I just went through with upregulation and downregulation and this and that and the other thing. We can measure opiate withdrawal very easily. It takes less time to measure it than it does to take a blood pressure, a pulse, and a weight in a doctor's office. And I'll go through that. The only thing I'll say about the different agents that people become addicted to, and I'm speaking specifically of opioids now, shorter acting opioids like oxycodone or heroin, within 12 hours of stopping use, there'll be withdrawal. But some are slow release opiates, the extended release, and things like methadone that are actually longer at the receptor. The slow release are just continually releasing. They're not actually longer acting at the receptor, but that's 32 hours. So you don't want to, when somebody is going to start buprenorphine, you want to make sure they're in enough withdrawal that it will help them and not put them in more withdrawal, even though we have something to do with that. In the old days, it used to be, you know, let's put you in the hospital for a week. The worst will be over and you can get on with your life. Well, that was very naive. When 4 to 6 days, the worst is over is hardly true. The worst part comes later when the great anhedonia from not having your upregulation in place and having the neurotransmitters back pumping in like they should have, that can take 6, 12, 18, 24 months. So the worst is not over, and this defines why we have recurrence of disease. So don't we wish that the acute withdrawal was all there was? The protracted withdrawal is what makes addiction a chronic disease. Okay, so perhaps some of you have treated patients or seen patients in whatever setting with acute withdrawal. It's pretty miserable, and most people will never go through it twice. They'll do whatever they have to do not to go through it again. Even when it's coming on, they may never go through it once because they say, I'm already not liking it, and they will find their drug. And whether that drug is caffeine, my friends, on a Saturday morning when you forgot to have your cup before work, or whether it's opiates. So this is a pretty measurable withdrawal. You can tell it almost if the patient doesn't speak to you by having a patient in a room. So that's the acute withdrawal. The protracted withdrawal that goes on and on, again, that's a real challenge. We can measure the patient's idea of how their withdrawal is. And I'm sorry, this is a little blurry, but these are easy to pull off the internet. The subjective opiate withdrawal scale, they'll talk about these symptoms they're having. They're anxious, they're yawning, their eyes are tearing, their nose is running. They get a little abdominal distress. They might have had diarrhea, and they may have chicken skin, piloerection. So we can measure all that. And we can tell them, look, we're going to start you on this medication, but we start you when you're in some type of moderate withdrawal. So you keep track, and then we'll keep track too. So you let them know, and patients that have been through this know all these symptoms, and believe me, they never want to go through it again. Oh gosh, darn, missed this one. Oh yeah, okay. So this is the way a clinician measures the withdrawal. This is the clinical opiate withdrawal scale, and you can pin it down pretty good. Pulse rate, sweating, restlessness, and we give a number from 1 to 4 to all of those. And some of them are subjective. Are you having any pain? That's fairly subjective unless you can see it. Restlessness, but we can measure enough of this, and surely if their eyes are, pupil size is large, their pulse rate is over 90, and they got chicken skin, they're ready for a dose. But usually we'll say you want to be at about 13 on this scale before you start buprenorphine. This is very easy to do. Staff can do it. You can do it almost without the score sheet once you've done a few. So it's very obvious opiate withdrawal when you see it, but it can be measured, and you want to put that in the chart. And the patient, I've always brought patients through this in the teams I'm with, tell them what it's going to be like and what we're going to do. So back to this slide for the last time. So now you've got a patient that's replaced their own enkephalin or endorphin with morphine or oxycodone or hydrocodone or fentanyl. And now we've got on the left buprenorphine that we can put in there. It will take away the withdrawal, it'll take away the craving, and it'll block opiates when other opiates when they come in. It's a great medication. side effects are so little, it's remarkable. Very rare to have any side effects at all. So this is the game. It's at a molecular level. And how do we start patients on Bupe? Okay, so I'm going to turn you all into eggheads now. If all those slides weren't enough, we're going to talk about eggs. So one way of visualizing opiate withdrawal is to think of a dozen eggs as your receptors. Just think that's your whole deck of opiate receptors. And whether your doctor took you off your morphine, or whether there's no fentanyl or heroin in town, or whether you can't steal your auntie's oxycodone anymore, those receptors start emptying out. And that withdrawal starts. By the time you're at one egg left, and certainly no eggs left, the average person will be in despair. So I would say that the second picture is probably a opiate withdrawal score of 13 to 20. And you can start that person there, because the buprenorphine will go right in and fill those empty receptors. And those empty receptors, they're like a little Pac-Man wanting to bite, wanting something, give me something. Because the withdrawal, again, it's rare to see anybody go through it twice. They just won't do it. Okay, so there's 3 ways to start the Bupe. I'm going to go through each of these. And the first is a traditional start. We wait for a COWS score of 13. You give buprenorphine in the pill or in the sublingual in 4 milligram increments every half hour until they feel fine. And you just play it by ear. And the average, national average, is 16 milligrams by the end of the second day. Some people only need 8, some only need 6, some need 12, some need 32. So that's rare, but it happens, and I'll talk about it. The microdosing has become very popular for a reason I'll show you, and the rapid start is probably the best because you get the job done while the patient's with you. So this is the traditional start. There's your receptors all full. Now you've got a COWS score of 13. The patient is uncomfortable. They're sweating, they got chicken skin, they're yawning, they're anxious, they want to go run, they want to go, they're craving opiates. And you give them a total of 8 milligrams on the first day. Give them 4 milligrams, wait a half an hour, give them another 4 milligrams. Then they can go home, take another 8 that night if they want, or wait till the next day when they wake up. So up to 16 milligrams. And that patient will say, I can't believe this is happening. Within 2 days, always 3 days, patients will say, this has changed everything. They have no craving. They're not thinking about opioids. They have no physiologic withdrawal. So that's the traditional start, somewhat cautious, but it works, and it works fine. The next is the microdosing start. We start at a very low dose. And here's why. It's particularly with fentanyl and high dose heroin, but we can use it with others as well. So there's the full dozen eggs, but when someone on high dose heroin or fentanyl starts going into withdrawal, they won't wait long before looking to fill that receptor. And it's very hard for them to go through the withdrawal because with fentanyl, for instance, it comes on very quickly and it's very intense. In fact, fentanyl opiate withdrawal is the worst opiate withdrawal. You've probably read reports where people have their chest wall muscles are frozen, they can't breathe, and so they die. So that withdrawal with that muscle spasm is so extreme. So with microdosing, and we go over 5 or more days, we don't tell them to stop. We say, here's what we're going to do. We're going to start changing the ingredient in the receptor. So that first day, they give them 2 milligrams. Now they've got 1 brown egg and their dozen white eggs. And the next day, you work it up to another, increase the dose. The next day, increase the dose. And you increase the dose all the way up until you get all the buprenorphine in. And microdosing works fine. It takes a little patience. The patients avoid withdrawal. This is the real benefit. They avoid withdrawal. They can have a full receptors all full, and you can give them 1 bupe and it's find its way in there. Remember, it'll push out the heroin. It'll push out the morphine, oxycodone, etc., fentanyl. But you start slow and they won't know it, just like that dozen eggs you bought you thought were white, haha, they're actually all brown eggs. Okay, and the last way is what I call rapid start. This was pioneered by the emergency rooms. And one of the references had that. It's easy to get online. It's a very good reference if you're a clinician that prescribes and takes care of patients with this illness. It's worth reading that. It's got everything you could possibly know. Don't be scared by it. But basically what you do, patient comes in, they may be in a little bit of withdrawal, they may not. You can give them a little bit of buprenorphine and they'll have a little bit of withdrawal, and then you just start giving them more. So typically we can do this over 2 to 3 hours. It started in emergency departments across the country, and now it's used in many clinics because it gets the job done while the patient's in the office and they get on with their life and you know it's done, as opposed to what's going to happen if they go home, etc. So very effective. We have a summit coming up on May 9th. I hope any of you can come. If you're on the Big Island, come. May 9th in Waimea, Hawaii Island Task Force Summit. And one of our speakers, we think one of our speakers will be someone who was on fentanyl addicted, on buprenorphine for about 6 or 8 months, and then get on injectable. And he did this rapid induction, and is really good testimony to it. So those are the 3 ways. They're really easy. I'm going to finish up by talking again where I started, that death is a crude measure of health. But I would remind you that it's not the only measure we care about, although it's getting all the attention these days. So let me just go through that one more time, a little more death and dying from Kevin, and then another comment here. Uh-oh. Okay, so this is an old study from Baltimore. Baltimore was a hotbed of heroin overdose deaths. And this is looking at thousands of patients back in 2009. This is one of the key studies. As you can see, the green line, buprenorphine, became available in 2002, the overdose deaths in red. And you can see how as the buprenorphine went up, the opiate overdose deaths went down. Methadone availability increased, certainly contributed to that, but there's no question that buprenorphine was saving lives. How many lives does it save? The lives saved by Narcan are minuscule compared to the lives that can be saved by buprenorphine. So everyone's into Narcan, but when we mention Narcan, we sure as heck should be mentioning buprenorphine. If we don't, it's like we don't tell you about blood pressure medicines and cholesterol medications, but we tell you we're a clot buster when you have your stroke. Come on into the emergency room, we'll give you a clot buster. Well, come on, it's time to say Narcan, and the next sentence say buprenorphine. On the East Coast of America, where there's a lot of overdose deaths, the emergency responders not just have Narcan, as they do now everywhere in Hawaii, including the police, at least on our island. The emergency responders don't just carry Narcan, they carry Suboxone, because when that patient goes in withdrawal, then they're going to be craving again. So right there, they're giving them buprenorphine and taking away that withdrawal. So that's what this will come to one day if we can stay with it. Death is a crude measure of health. So here you go. This is I have a full page of references for these studies that are now quite expanded. And Bupe or methadone, but Bupe, there's plenty of studies showing this. So the general population death rate, let's say it's 100 people per 100,000 for years. It isn't. But if you look at opioid use disorder with no treatment, it's 600, 6 times the death rate. And if you look at a patient with opioid use disorder on buprenorphine, their death rate is down to about 180, less than 2 times. So this is a medication that works to save lives. And if you have a patient with opioid use disorder who is still living, which is a good thing, and taking prescribed buprenorphine, all of life gets better. There's numerous studies now showing that all drug use decreases. All drug use decreases.
And that's why you can't stop church hopping. So maybe you have to open your Bible since last night.
Okay, so everything else gets better besides drug use as well. What else gets better? Work, family, legal, you name it, self-respect, self-regard, it all gets better. Okay, there's always common questions. I'll answer these and then we'll open it up. Can you start someone on Bupe if they are using methamphetamine, cannabis, etc.? Yes, you can. In the same way that if you have a patient with heart failure, but they've also got kidney disease, but that you can't treat, you'd certainly treat their heart failure. So we don't exclude patients because they have addiction. Addiction is when you can't stop using. Don't we wish we had a medication for methamphetamine? So you can start someone if they're using other drugs. How about if they're using alcohol or benzodiazepines? They are high risk. Proceed with caution. And we usually want to start treating the alcohol use disorder and the benzodiazepine use disorder as soon as possible. And, you know, we do have, for alcohol use disorder, we have FDA approved medications that work fine if they're prescribed and taken. I don't know if that's someone asking a question or we're being Zoom bombed, but anyway, I'm going to keep going. Can you legally use Bupe for pain? Yes, you can. And if you refer to the November 2022 CDC guidelines, you'll say they actually mention it multiple times. So Bupe can be used for pain. There's no special restriction for using Bupe anymore if you're a provider and you have a registration with the DEA. And then briefly, startup and follow-up. Yes, the initial evaluation should include things like a urine drug screen, labs, treatment agreement, etc. Together is better means that not just medication, but doing anything. Most people cannot access IOP, treatment programs, even psychology, unless it's primary care, which is often limited primary care psychology. But together is better. So at a minimum, if you can get somebody to get into 12-step or someone who's been through this so that they know they're not alone and know what's happening. We follow up weekly at least for the first month, and then monthly, and then up to 3 months at the most. I think that's about it. Okay, that's it for me. I'll turn my pictures back on and I'll stop the sharing.
Okay, we've got lots of questions for you. Let's see. How can we convince addicts to get help? Oh,
Well,
let me rephrase that in proper language. How can we convince individuals who are interested in using substances to access programs that will improve their life?
Great. Well, Kelly, I think you did a great job on that. The first thing we can do, of course, is language. And if you call someone addict, they're going to act differently than if you call them something else. So, you know, if I tell you I have a random door prize for someone on this Zoom call today, and it's a weed, there wouldn't be many interested people. But if I says it's 4 dozen roses, it's going to be delivered to your house in about an hour, there'd be a lot of interested people. So addict is not a word we use. Dirty urine is not a word we use. What's that mean? Dirt in your urine? The urine either is positive or negative for a substance. So, okay. Now your question, you got me carried away. You know how I get, so sorry about that. Give me the basic question again.
What can we do to help folks get on treatment?
Yeah, first of all, anybody that mentions Narcan at all, ever, stop and say, what about Suboxone? What about buprenorphine? What about Bupe? So folks have to feel they're treated well, and they have to have care when they want to get it. And one of the problems is you try to access someone who's prescribing buprenorphine and it's hard to get them. Not all physicians, all providers licensed in the state of Hawaii with a controlled registration can prescribe buprenorphine. So psychologists and social workers should be referring these patients. The primary care practitioners need to get on board with this. This is a more deadly disease than high blood pressure. It is in fact more deadly than cancer in the long run and more expensive. So it's a big job to get healthcare involved. You know, I heard this the other day. Someone said that doctor hasn't forgotten anything he learned 40 years ago. Well, that's right. Most of us come out of our training, and this is a modern crisis, and we're living in the past. So we need to move folks into the current real world. And the real world isn't the fancy technology world. It's caring for patients that are looking for help. So that's a big block. That's systemic discrimination I would refer to again. And that's really the obligation of each of us to reach out. And I will add that with buprenorphine, the World Health Organization has a list of essential medications. It's less than 30 medications, aspirin, penicillin. Buprenorphine is on that. This is a global issue, but it's a safe, effective medication. And yet we don't use it. So healthcare's got a big problem. It needs to start training up in a different way. Locally, there are graduates from residency programs that don't know how to use buprenorphine. So there's a lot to do. Okay.
So there's question, well, okay, the question from before is, what can we do as individuals to help decrease utilization? Let's see. What can we do as people in general to help the opioid epidemic besides bringing awareness to resources? We've heard language. We've heard saying bupe in the same sentence whenever we say naloxone or Narcan. What else can we do?
If you're a
to
health
help.
professional, yes, if you're a health professional, you're already interacting with others in the healthcare system. You need to be a spokesperson for that if you know about it. When you see that patient in front of you, remember that you don't want to let them down, but you will. But you will if you don't get them the help they need. So you've got to educate your peers. Probably that's the most important job. This is not some, when we made addiction medicine a medical subspecialty, we studied other subspecialties, and there's actually a subspecialty called dermatopathology. This is not dermatopathology. This is America. This is the leading cause of death and despair and economic cost in America. So talk to these providers and let them know, my patients need help. If you can't help them, who can? So I think being an advocate at every level, an advocate for the patient, try to hook up with a provider who understands buprenorphine, is not scared of it, is not being influenced by stigma. It's getting so now that almost everybody in America has some family member has had addiction and some experience with it. So it's getting a little bit better because now maybe they're just regular people with a bad disease. Maybe they're good people with a bad disease, like Alzheimer's or something. So
Leilani,
become an advocate.
Advocate. Okay, language, advocate, recommend it.
A relationship with a provider. If you're not a provider directly, have a relationship with a provider.
Got it. Leilani says she appreciates your compassion and the empathic way you speak about people who use drugs. She just doesn't hear that enough from people who work in healthcare here. So spreading that is important. And then Ella asks how the folks who use substances can afford more substances, but not food or shelter.
Well, the nature of addiction is food and shelter is not important. Your children are not important. Your health is not important. Jail is not important. The only thing that is important is getting them eggs in that basket. That's it. That's it. And that's the most important food there is. Remarkably, buprenorphine is covered by all insurances. And even if you don't have insurance, using GoodRx or one of the other discount programs available online, it's cheaper than anything you could buy on the street. I think for about $300, $350 a month, you can get buprenorphine at an adequate dose. So paying cash with a coupon. So it's covered by all insurances. The hard part is, I think for patients and for providers, is having that relationship with them. I'll just tell you this one story. So about 10 years ago, I would eat lunch in my woodworker friend's shop. And one day a guy came in to pick up his chest of drawers or whatever was being made. And my friend introduced me as a local doctor. And this guy was a heart transplant doctor. And so I just shook his hand and said hello. And then he said, "You're doing something really worthwhile with your career. I wish I had thought of something like that." And you know what? I feel that way. I feel that each of you that has the ability to connect with a patient can change their life and the life of their family and their community in a way greater than any heart transplant surgeon changes the life of one person. And even if they did 1,000 heart transplants in their lifetime and their families. So, it is feet on the ground, heart to heart. That's what makes a difference. The patient knows you care.
Ella asked, do you have any problem with those on Bupe continuing to take opioids?
Well, they eventually will stop, but no, I do not. The truth is, someone gave a lecture on a 12-step program, Narcotics Anonymous program, and somebody said something like, "Why do I got to go through all that stuff for?" And he says, "Well, if you could do it in one step, that would be great. But we have 12 steps here because you do a little at a time." And that's the real world. So you're not going to, many people won't stop right away. If they have an adequate dose of buprenorphine and it's not being diverted, if they're taking it, there's no way that they will keep using, because one, it blocks the receptors. And it's like taking nothing, because buprenorphine is going to want to be in there and stay. Nothing's going to push it out. No opiate will push it out. So be patient, work with them, walk the walk with them.
Wonderful. Okay, well, you have some appreciation in the chat. I want to tell folks next week we have pain treatment with Luda, I'm going to say this wrong, Dyachenko, MD, PhD. And everybody wants information on the conference you mentioned in June. So if you can get that to me and or Summer, we can get that out to the group, as well as there is a conference. I think it's June 7th on Kauai. So there are conferences this June. So we'll get everybody that information. So Susan Wada says, "Thank you. You make a complex issue simple. Awesome training. Thanks. Excellent information. Much thanks. Thank you for this info. I was too late to help my brother, who I lost to an accidental fentanyl overdose. I wasn't aware of the signs to look for." Oh, great presentation. Thank you. I think education is definitely a priority. This is one of the most valuable webinars I've taken. Thank you so much, Dr. Kunz. I think that's it.
Thank you all.
So thank you so much. And thank you everybody for taking part. And this will be up on the webpage probably by next week. And we will get you the information on the conference.